Positioning Lesson 16 is Pediatric Radiographic Procedures. 13 minutes on radiation sensitivity, immobilization, shielding, age-appropriate communication, and the special conditions that pediatric radiography requires. Children are not small adults. Their technique, their equipment, their communication, and their dose management all require specific adaptation. Why pediatric radiation dose matters more than adult dose. Bergonié-Tribondeau law. Cells are most radiosensitive when they are rapidly dividing, undifferentiated, and actively growing. Children's tissues satisfy all three criteria throughout childhood, especially bone marrow, gonads, lens of the eye, and thyroid. Children are estimated to be 2 to 3 times more radiosensitive than adults for the same dose. Image gently. The National Pediatric Radiation Protection Campaign defines 5 principles. Reduce. Use lower MAS than adult technique. Shield. Gonadal and thyroid protection on every appropriate exam. Speed. Use the fastest IR and shortest exposure time possible. Limit. Take only the images clinically necessary. And justify. Every exam should have a clear clinical indication. Is this exam truly necessary? Pediatric technique charts. Never scale adult technique by patient weight. Pediatric tissues have different attenuation characteristics than adults. Age and size. Specific charts must be used. Generally, higher KVP than you might expect. Pediatric patients are thin, so penetration is not the challenge. Combined with lower MAS, adequate exposure at minimum dose. AC systems have a minimum response time. The shortest exposure the system can terminate. In very small or thin pediatric patients, the correct exposure may be shorter than this minimum. The AC keeps exposing past the target dose. Use manual technique for very young or small patients. Use the highest available MA setting, shortest exposure time, for motion control. Motion is the #1 cause of non-diagnostic pediatric images. Short exposure time is the best motion control. Immobilization devices are the backup. Pigg-O-Stat, designed specifically for upright chest radiography in infants and toddlers. The child sits inside a rotating plastic cradle with the arms elevated by the device sides, clearing the lung fields. Produces a PA upright chest without anyone in the primary beam. Standard for infants through approximately 3 years of age. This is the most commonly tested pediatric immobilization device on the ARRT. Mummy wrap, also called octostop, a sheet or Velcro wrap that restrains the arms and legs. Used for non-chest procedures where the Pigg-O-Stat is not appropriate. Sandbags, placed at the periphery of the anatomy outside the primary beam. Hold position without entering the field. Velcro straps for head and body stabilization. Parent-assisted positioning. A parent may hold the child during exposure, often preferable to mechanical restraint because it reduces anxiety and improves patient cooperation. The parent must wear a lead apron, minimum 0.5 millimeter lead equivalent. The parent must be notified that they should not hold the patient if they are pregnant. Parent holds the child outside the primary beam, hands and body shielded. Document, quote, parent present with lead apron applied, unquote, on the requisition. Gonadal and thyroid shielding, applied on every appropriate exam. Male, flat contact shield or shadow shield over the testes when they are not in the primary field. Female, contact shield over the ovaries when it does not obscure anatomy of interest. Thyroid collar, for all upper chest and neck examinations. Shadow shields, suspended from the tube collimator, are used when direct contact shielding is impractical. Never shield if the shield would cover the anatomy of clinical interest. Collimation. Pediatric fields must be tightly collimated. Every centimeter of additional field beyond the anatomy of interest adds measurable dose to radiosensitive growing tissue. Collimate to the anatomy, not to the IR size. Age-appropriate communication. Infants, 0 to 1 year. Speak to the parent. The infant cannot understand or follow instructions. Use fastest technique, immobilize. Toddlers, 1 to 3 years. Simple words, reassurance. Demonstrate on a stuffed animal. Distract with parents' help. Preschool, 3 to 5. Tell them what you are doing as you do it. Quote, hold still like a statue, unquote, works well. School age, 5 to 12. Explain the procedure honestly, answer questions, involve them in their own care. Teens, treat with adult respect and appropriate privacy. Offer to ask parents to step out if appropriate. For clinical conditions with specific pediatric radiography implications. Pediatric chest. PA erect using the Pigg-O-Stat preferred for infants. AP supine if the child is too ill to be positioned upright. KVP, 60 to 70. Lower than adults because pediatric chest is thin. The thymus in young children, infants and toddlers, is normally large. It may appear as a sales sign, a triangular opacity extending from the mediastinum into the right lung field. This is a normal finding, not a mass. Do not mistake normal thymus for pathology. DDH, developmental dysplasia of the hip. Standard AP pelvis. Hilgenrainer's line drawn horizontally through both triradiate cartilages. Perkins line vertical through the lateral acetabular edge. Normal, femoral head ossification center in the lower medial quadrant. Shinton's line, a smooth arc from the medial femoral neck to the inferior pubic ramus. Disruption indicates dislocation. Ultrasound is preferred for infants under 6 months before ossification. Intussusception reduction. Air or contrast enema under fluoroscopy. Bowel telescopes into adjacent bowel, usually ileocolic. Pneumatic air pressure reduction, controlled and monitored. Surgical backup required during the procedure. Success confirmed by reflux of air or contrast into the terminal ileum. Contraindicated if perforation suspected. Non-accidental trauma, skeletal survey. When child abuse is suspected, a full skeletal survey is mandated. All films on the same visit. Classic specific findings. Posterior rib fractures from squeezing and classic metaphyseal lesions. Corner or bucket handle fractures at long bone ends from pulling or shaking forces. These patterns in non-ambulatory infants require mandatory reporting to Child Protective Services and immediate physician notification. 3 pediatric radiography questions. The answer is B, Pigg-O-Stat. The Pigg-O-Stat is designed specifically for upright PA, chest radiography, in infants and toddlers. The child sits inside the rotating cradle with arms elevated by the device, clearing the lung fields. A true PA upright chest is obtained without requiring anyone to be in the primary beam. It is the standard of care for pediatric chest radiography in children up to approximately 3 years old. The answer is B. The AEC minimum response time may be shorter than the correct pediatric exposure, so manual technique with high MA prevents overexposure. In very thin or small pediatric patients, the correct exposure time can be shorter than the AECS minimum response time. The AEC keeps the beam on past the target dose, causing systematic overexposure. Manual technique using the highest available MA setting gives the shortest exposure time while delivering a controlled appropriate dose. The answer is C, posterior rib fractures and classic metaphyseal lesions. Posterior rib fractures are caused by forceful gripping and squeezing of the infant chest. Classic metaphyseal lesions, corner or bucket handle fractures at the ends of long bones, are caused by violent pulling or shaking forces applied to the limbs. These specific injury patterns are extremely rare from accidental mechanisms in non-ambulatory infants and are the most specific radiographic indicators of non-accidental trauma. Lesson 16 complete. Bergonié-Tribondeau H law, image gently 5 principles, pediatric technique charts, and AEC limitations, Pigg-O-Stat and mummy wrap immobilization, parent positioning with lead apron requirements, age-appropriate communication for each developmental stage, gonadal and thyroid shielding, normal thymus versus pathology, DDH evaluation, intussusception reduction, and skeletal survey with the specific findings of non-accidental trauma.